Okay, so now coming back to the general questions regarding the IC, what protocol do you think should be followed to diagnose IC?
Yeah, now that's such an important question because if you go by international guidelines, European guidelines, American guidelines, RCUG guidelines, every country has devised their system. And how do we go about it? Because there is a proper referral system there. They know their patient will be first going to a physician, then they will go for a specialist referral, then there is a certain way those countries perform that A plus B equal to C plus D. So this has to be there, this has to be there, and then we go for cystoscopy, and it's not mandatory. The treatment can be started. Sadly, our Indian guidelines are still not in place. And trust me, Balka, our patients are coming from far, far places. They reach to me after seeing at least 10 doctors, which include physicians, which include gynecologists, which include urologists. All over India, they come and they find us and they try to reach us. Now, people who have already taken medications, who have tried multiple things, they are already on antidepressants, and they want some conclusion, some diagnosis कि है क्या पता नहीं चल रहा है, सब report तो ठीक है. Now, these cases, if I really want to design a protocol, I'll rather do a cystoscopy, put it in black and white. Now, technically speaking, international guidelines say that a cystoscopy is not mandatory to diagnose IC, and based on symptoms, you can start treatment and it can be diagnosed. But I feel personally, at some point of time, unless you prove or disprove yourself, though I know 10 to 15% of IC cases, cystoscopy can be totally apparently looking normal, and the changes can be microscopic, and even biopsies may not always will prove it or disprove it. So it's a mix of what patient is telling you, what cystoscopy is telling you, what a biopsy is telling you. But at the end of it, what do I want to do? I want to treat and cure my patients for a disease which is not curable. So somewhere I need to put in black and white कि इस patient को IC है या नहीं है, because ये patient मेरे पास 20 लोगों को दिखाने के बाद आया है. So in my protocol, cystoscopy do come early because I want to say it yes or no. A confused patient, a rejected, dejected patient with this big file, this potha of reports, has come with a hope to me कि मुझे IC है कि नहीं है, क्या है. And I want to keep up to that hope कि मुझे prove करने दो कि है या नहीं है. So for me, protocols में cystoscopy do come early because it gives me a chance कि उसी sitting में अगर IC है तो मैं पहला distinction कर दूं. Intravesical installation उसी sitting में डाल दूं so that my patient is okay. Because aim क्या है? Patient को ठीक करना. Diagnosis बनाना is not the aim. Eventually मुझे treat करना है. And that cystoscopy gives me a chance to see things with my eyes. So मेरे protocols में cystoscopy थोड़ा जल्दी आता है as compared to international guidelines. But those who follow that protocol strictly, कि आप पहले मेडिसिन ट्राई करेंगे, फ्रीक्वेंसी अर्जेंसी को ट्रीट करेंगे, वाटर इनटेक सेटल करेंगे, उसके बाद आप पेंटोजन या दूसरे मेडिकेशंस पे जाएंगे, और उसके बाद आप फिर पेल्विक फ्लोर थेरेपी भी इन्वॉल्व करोगे, पेन मैनेजमेंट करोगे. सिस्टोस्कोपी इज लाइक अ पैरेलल थिंग गोइंग. So though they are not wrong, I will still say that every patient needs to be customized, individualized, and see where they are coming from and what's the mental state right now. So protocols are flexible in my case. They are absolute in abroad countries. We can't bypass them. But here we don't have an absolute protocol to be followed strictly.
Work on our own protocol. So, do you think that all IC patients they need installations, or
No, not really. Not really. See, any invasive treatment modality like installation, it for me, I'll keep that as my backup. Just like that standard protocol कि हर 2 हफ्ते में आपको डालने हैं 6 installations. I don't really strictly follow that, and that's my way. And so far, it's working well because the oral medications for IC, whatever we give, whether it is pantozan in a different form, cystopen hai, pantozan hai, whatever, Comfora hai, whatever brand names it comes, it takes 3 months for it to show its effects in full doses while we are sailing through the patient through that gap time. where the body is still adjusting. We are still figuring out kitne side effects hain, kitna effects hain. And to patch up that phase, I need something as backup to manage as flares. So I don't put patients straight on intravesical installation in the beginning itself, कि जहाँ 6 इंस्टॉलेशंस के बाद मेरे पास कुछ नहीं बचा है अब एक फ्लेयर को मैनेज करने के लिए. So you knowing all the technical details कि installations क्या है, medicine क्या है, and for those who don't know, intravesical installation is where we put the medicine directly in the bladder. And अगर मैंने 6 बार दे दिया तो मेरे पास क्या बचा? अगले फ्लेयर में मैं क्या करूंगी? Because I know flares are bound to happen. So for me, installations are my backup. They are my backup while my patient is still going on a protocol based triple therapy. Yes, if triple therapy is done completely और बीच में एक दो बार installation as a rescue देने के बाद भी नहीं ठीक हुआ, then my second step is back to back 2 weeks का 6 installations. And in installations, what work, what doesn't work. There was a time जब हम heparin डालते थे, अब heparin withdraw कर लिया है मैंने because I realized it's triggering. सोडा बाइकअप डालते थे, अब वो सोडा बाइकअप आई नो का वो पार्टिकुलेट कर देता है सॉल्यूशन को, सो इट मे ट्रिगर दैट दोज फ्लेकी थिंग्स बिकॉज इट्स लाइक फॉरेन पार्टिकल्स. So a lot of things evolve in your own practice. Now new medication tacrolimus has come in, so now that can be instilled. So depending on installation is a route. Medicine में क्या डालना चाह रही हूँ, that becomes my rescue, and I keep upgrading them as and when needed because I see something which is going to be there. तो कुछ तो होना चाहिए ना मेरे हाथ में. So I don't make it mandatory for all. I use it wisely. किस patient में कब क्या, and depending on patient's resistance to one certain level of medication, I upgrade it to another set of medications and installations. So till date installations में बहुत जाना ही नहीं पड़ा है मुझे, at least in last 9 years in Mumbai. I generally try to mix and match things. And installations, I won't say it's mandatory for all unless I feel कि बहुत ही खराब केस है सिस्टोस्कोपी में और शुरू में दे दो as a loading
And
dose.
for the viewers, could you just explain triple therapy?
Okay, now
Many
the triple
wouldn't know it.
therapy, yeah, it's like means it is our self-devised term कि triple therapy में हम क्या दें. Now हमको ये नहीं पता है कि interstitial cystitis का original cause क्या है. We don't know. Is it just inflammation idiopathically happening in the body? We don't know. It is an allergic response to whatever you are eating. लोग ही बताते हैं कि हमने आज खट्टा खाया, तीखा खाया, काली मिर्च खाया, उससे हो गया. What is this? Means it is like an allergic response, and that's why bladder में mast cells बढ़ गए हैं. That's what we say. So कौन से कारण से क्या हो रहा है हमें नहीं पता है. So triple therapy में है क्या कि we try to work on these 3 aspects. Allergic component hata de. So what I add is one anti-allergic, a strong one. Now again, I'm modifying slowly कि simple hydroxyzines से जो हम पहले atarax की तरह से use करते आ रहे हैं, उसको क्या मैं Montelukast combination से change कर दूं, Allegra M or Levotizem. So one strong anti-allergic which can control histamine release, which can stabilize the mast cells. Now, a lot of advancements are coming on mast cell stabilizers. So I'm looking at pharmacology these days कि क्या नए compounds हैं जो mast cells को stabilize कर सकते हैं. This becomes one part of triple therapy. Now, the second part is to reduce the spasmodic effect of the bladder and at the same time relaxes the pelvic muscles. So a little bit component of medicine which can work for relaxing the central nervous system as well as pelvic muscle spasm and give some anticholinergic effect to the bladder if you're aware of these terms. So amitriptyline or a nortriptyline component works very well because it has little component of all. So that becomes a second part of my triple therapy. And then gabapentin, a neurogenic element because the nerves of the pelvis have become so tensed. They are like sort of pulling, screaming, pain. They are irritated nerves and they have sensitized the whole perception of the central nervous system towards this pain. So gabapentin or pregabalin, this becomes the third arm of my triple therapy. So these 3 things work together from the pharmacology point of view, while in the parallel time, my pelvic floor therapist relaxes the pelvic muscles. my counseling techniques, because I do that part myself. I like to do that. I'm so much into it because I know the perception of pain, the cognitive behavior therapy, rational emotive behavior therapy, in the meantime, works to calm down that sensitization and acceptance of the pain, that the catastrophic nature of this pain has to has to be brought down slowly. So while these other modalities and my pain specialist is working together, triple therapy gives me that time. So these three medicines are my rescue medicine, which every patient goes for 3 months, while pantozan is working on the mucosa to heal. So that's what is triple therapy is. But again, there is no absolute protocols. Every practitioner has to see their practice, their experience with these medicine, and then customize, individualize.
So you said that you have pelvic therapist in your clinic because most
Yeah, we
IC
have a
patients are
person in team.
struggling to find pelvic floor therapy.
Yes, yes.
And
I'm lucky to have that kind of a specialist. I did find a pelvic floor rehab specialist in my area, and she works on those patients who are facing parallel vaginismus, pelvic trigger points. Like I say, I cannot do it all. No one can do it all. And there has to be different person जिसमें pelvic spasm का component बहुत ज़्यादा है जो मुझे examination पे feel हो रहा है. Somebody who has not been able to consummate the marriage, has never even spoken about it because all the time there was a male doctor talking and trying to just fix the pain and frequency urgency, never even opened up. Now, being a sexual dysfunction specialist for women, we do touch upon those intimate aspects of life. And when we come across that a pelvic floor spasm has significantly affected the intimacy of relationship while the lady is going through urine problems, we try to fix that. So a pelvic physiotherapist is the crucial where these components are strong. Many times pelvic spasm releases, the trigger points go away, pelvic stretches help, and the pain is gone. Bladder settles down. Helps me so much that I can withdraw medication slowly in 3 months. So that's crucial. That's very much needed. And I mean, I'm lucky to find a pelvic floor
it's
PT, a
good to
very
know
good
that
PT.
because then we can refer our patients there. Now that you
Definitely.
mentioned sexual dysfunction, I would like you to elaborate on this because this is from my experience that I have seen that whenever patients come to me, they talk about everything, frequency, urgency, pain, everything, but they are kind of not very comfortable talking about their sexual life. But
True.
when I start talking to them elaborately, they slowly they open up. And I have realized that sexual dysfunction plays a very crucial role in the life of IC patients, but something that neither the patients are comfortable talking about nor the doctors are comfortable because as it happens, most of us go to
Yeah.
urologist who is a male,
Right.
we don't feel comfortable, and then there is maybe also a guilt shame factor happening. So now that you spoke about it, I would really like you to elaborate on this and share some experiences or
Sure, sure,
insights.
sure. डेफिनेटली सी क्या है ना बालिका, अपने कंट्री में अपने एशियन कल्चर में ना, एक तो अ वुमन टॉकिंग अबाउट सेक्स इटसेल्फ इज सच अ बिग टैबू. A woman asking for sex, discussing sex, leave apart patients, even in doctors, there's so much of hesitation. Even in our gynec training, we were never taught about speaking about sexual dysfunction to women. It was never given that importance. The quality of sexual life was never a part of asking histories. It is only in last 5 to 10 years that women have become vocal, and I'm happy to see that the medical science also is opened its doors as a lot of research coming up. People are vocal about the needs. And the thing in IC patients, when we're talking about everything about pelvic floor, now sexual function is such an important aspect of pelvic floor. We talk about urinary symptoms, we talk about bowel symptoms, we forget that between the urinary opening and the motion opening there is a space called vagina, and a lady has sexual needs, and because of the vaginal pain, because the bladder is sitting right next to that vagina which is inflamed, is in spasm, plus the motion area, the rectum, the IBS symptoms, which generally are coexistent with IC patients. Endometriosis is coexistent in IC patients. There are so many other things, fibromyalgias and pelvic spasm. What is happening to the sexual life of a couple? Now, not just women, the male partner is a silent sufferer in this. And basically, it's not the male or female, it's the relationship which suffers. Where there is, the woman is going through a low self esteem, there is definitely guilt that I'm not able to accomplish a relationship the way it should be. The fertility questions arises क्योंकि relations ही नहीं हो पा रहे हैं, sexual relation accomplish नहीं हो रहे हैं, how will I think of a family yet? Right. So there's so much of frustration built it up. I have seen male partners coming with the wives and they just sit like, like taking a very backstage कि इतना सब वो उनका prescription देख के मैडम आपको जो करना है इसका ठीक कर दो मैं तो थक चुका हूँ. And I see so much of rejection on the face of the lady that the partner is not even able to understand. Now, how do I see them feeling intimate for each other? Because one partner is emotionally drained, financially drained, mentally drained, कि ये तो ठीक ही नहीं होती है. And the lady is so much in depression that how do I explain कि मुझे real problem है. The pain is not, I'm faking it. So there is first thing which goes out of the door is physical intimacy, and sadly over number of years it makes the couple go like this. The emotional intimacy starts going off. The worst part is that there is the real medical reason behind it. It's not psychological. There are true real reasons कि bladder पूरा inflamed है अंदर से. There are continuous urinary symptoms, and there is, whenever there will be an attempt to penetrative intercourse, there is a fear of pain. There are triggers. The bladder will again go in spasm. It will trigger the flare. They are real. How do we settle that? So, counseling of couple is important. The male partner accepting that it's a real medical condition, it's not just a psychiatric issue. That's important. And there has to be a time where both of them knows that we are healing together in it. And there comes the role of a good pelvic physiotherapist who gives that confidence. And one more thing I would like to highlight, Palka, that, in our Indian mindset or worldwide, we equate sexual intercourse equal to penetrative intercourse. Sex means penetration, penetration accomplishment means intercourse accomplishment. We need to teach in general couples that intimacy is emotional intimacy first. Emotional intimacy goes toward physical intimacy, and then comes sexual intimacy, and not every act of sexual intimacy should or must equate to sexual penetrative intercourse. So, a lot of counseling is involved while we deal with female sexual issues or the issues of the couple with IC as a background, where we help them to build intimacy first. The pleasure part of an intimate relation, starting from emotions, talking out, spending quality time, then go toward physical non-genital intimacy, that don't think of genitals in a sexual intercourse or a sexual intimacy. Build intimacy in non-genital ways, and then at certain point, once the pain is settled, once the pelvic muscle is relaxed, once the mind of the lady is relaxed, then we go and take that step towards penetration. So it becomes a long, elaborate, separated, filtered process rather than sex means intercourse, penetration means pain. So we break that, and that's what is REBT all about, which is rational emotive behavior therapy.